The next speaker, and I'm really pleased to welcome Karen Goudie, who is Chief of Nursing Services at NHS Lanarkshire at University Hospital Monklands. Karen's got a long kind of background in quality improvement. She was a Scottish Improvement Leader graduate, and she, prior to working in NHS Lanarkshire, she was doing older person health in NHS Fife. She has also undertaken the role of National Clinical Lead for Older People Healthcare Improvement Scotland, and she was involved in the early work around excellence of care. So she's got an excellent perspective, and I'm really pleased to welcome her to talk about the Lanarkshire experience, which was using Patientrack. Over to you, Karen.
Thank you. Thanks, everyone. Lovely to see some familiar names in the chat box as well. So it's nice to actually get out and about again, isn't it, and present some of the good work we're doing through these difficult times we've been having over the last couple of years. So first slide, please. I'll just move on. So thanks for that introduction. I get a wee bit embarrassed there when you were saying that. So I have been interested in early warning score and reliability around early warning scoring probably since my days in Stirling Royal Infirmary, where I was a hospital at night, ANP, and we used to team up with the junior doctors to develop an improvement project. And our first, one of my first improvement projects using QI methodology was around reliability of early warning score overnight. And that experience kind of came around when you're a new ANP with the FY1s, you know, finding patients in quite a state of deterioration. You know, what else could we do to kind of capture these patients earlier on? And that's where we carried out our first MQI project. So I've been interested in this for a long time and got the chance to kind of influence what we do here at NHS Lanarkshire. Also lucky enough to have worked with Gavin Simpson in NHS Fife, and that's where my interest in Patientrack kind of was born. Gavin and I worked together looking at frailty and delirium with the team up in Fife and how we could use the system just to identify some of those signs of deterioration in older people. So the drivers I don't need to explain to the people in the room, but one of the important drivers for us here in NHS Lanarkshire is the new Monklands Hospital. So the ambition for that new build, it's going to be one of the largest capital projects, you know, after the QE in NHS Scotland, is to be a fully digital hospital and carbon neutral hospital. So this is where we had the opportunity a couple of years ago to think about what digital solutions can we test in the live environment, and Patientrack was one of those kind of innovation projects that we put forward to test here on the Monklands site, but obviously thinking about how we could spread that improvement across our NHS boards. Next slide, please. So being a brand new chief nurse, you know, in partnership with the chief of medicine, we obviously have a huge part to play in terms of looking at reliability of systems, quality and safety, but also reviewing SAREs and commissioning SAREs when things go wrong across the site. And one thing that we were picking up quite quickly after I arrived was around that kind of lack of recognition of deterioration across the site. So it made us go and have a look. And we carried out some measurement using the SPSP bundle around reliability, around early warning score, and just a bar chart here, just detailing the bundle compliance across the hospitals. So 27% reliability across the bundle elements, and that was not an easy, you know, finding to then go and report to help people understand that we had a real problem here, and how did we understand and unpick where the kind of human factor issues were, or what was the barriers in terms of escalating patients, particularly in the out of hours periods, is what we picked up in the measurement piece that we carried out. We use a system in NHS Lanarkshire, which I'm sure many of you use, care assurance systems that will use methodology of sampling, you know, notes or sampling process across your wards, and ours is called LandQuip. And when I looked on that, the entire site here in Monklands looked as if everything was fine, you know, everything was either 95 or 100% reliable. But actually when we looked and used some QI methodology, but also sampling that was precise and using people that didn't work in those areas as well. I think that was quite important, that the findings were very, very different. So also revealed that we probably had a bit of false reassurance in our system around process measurement, around early warning score reliability, particularly around frequency and accuracy of early warning score. So this in turn, gave us a problem that we had to deal with, but the timing was just perfect because MRP, the Monklands Replacement Project, was just kicking off and we were looking for innovation projects. And fortunately, we got the go-ahead to test Patientrack in a couple of wards here in Monklands to see if that was a particular piece of innovation that we'd want to take to the new digital hospital for the new Monklands. So next slide, please. And what we found, through that measurement piece and through discussion with staff is, the ability to recognise deterioration, confidence in those staff members around, the human factors, what we were doing at our huddles in terms of talking about people, the sickest people in the building. Did we actually talk through that? And certainly my experience working with Gavin and Fife, the whole hospital huddles there, the first thing that was always spoken about was who's the sickest people in the building, and the response to those individuals was the first thing that was spoken about. So we worked to try and develop that conversation right through the whole hospital huddles as we pause as a clinical team throughout the day, and I'll go on to talk a wee bit through that. So again, just looking at how things fall through the net, we all know about this around frequency, inaccurate observations, scoring that wasn't accurate as well was another piece, and patient harm would be that kind of end point. And Gavin spoke eloquently about the communication piece, and I guess that's what we found, that communication was one of the biggest barriers in terms of that escalation and ability to recognise, where the sickest people were across the site, despite having an outreach team through our HEC team, despite having, good presence at the huddle from anaesthetics and ICU, we just needed something extra. So the test went forwards. Next slide, please. Thank you. So this is just some screen grabs from Patientrack. So Patientrack's the system that NHS Fife use and NHS Lanarkshire as well. So we started the test with 4 wards here in Monklands. I'll go on to describe some of the measurement we use. Right up to today, where eObs is now fully implemented across all 3 acute hospitals. And also we will be spreading the system out into some of the community sites as well, so that we've got that whole oversight of NHS Lanarkshire, if you like. In terms of Monklands Hospital, we also embarked on thinking about what could we do differently in terms of whole system, in terms of our huddle. So the picture on the right-hand side of your screen is our command and control centre. So that's where we pull numerous pieces of intelligence across the site. So things that you'll all be familiar with. So track care, our bed state dashboard, the ambulance arrival screen, Opera's in there as well. The floor plan for ED, but also we've added in Patientrack. So now we can see the clinical measurement piece as well as the operational piece in terms of running the hospital day to day, but also making sure that the plans that we need to put in place for teams to respond to are known by everyone. And that's done through kind of rapid conversations through the huddle. And I'll talk about that a wee bit later on. But you'll see here a wee screen grab from Patientrack where the patients, are visible, and we, at the same as Gavin, the same as Nikki, we will put up that information, that intelligence first thing in the morning, talk through the sickest patients. Roughly we had about 10 patients scoring a red or an amber this morning. The team are then able to reassure me or whoever's leading the huddle that that patient's either been reviewed overnight by HECS and ICU are involved, or there's a plan in place and we're waiting for treatment to end and discovering, what other things we need to do or referrals that are required in the morning. But also if that patient is end of life, that the team can then flag that patient to us, so say that that patient's end of life and not for observation, that we're able to then make sure that we are not continuing treatment and care that's not appropriate, particularly when people have got TELPs, etc. in place, and DNA CPR. So all of that information is flagged by the nurse and staff and handed over in the morning by a rapid review of those patients. Next slide, please. So here's the system itself. So what I'll explain a wee bit so people don't know. So the nursing staff traditionally would have had the paper-based system. So we've now moved to an iPad iPads in every ward area, or any tablet. We can use other tablets. I suppose I shouldn't be mentioning Apple, but I've just done it. So we use iPads across the site. So observations are put into that iPad, etc., and then the nurse will be given, that detailed kind of summary of people's parameters. And the system itself, is pretty foolproof. So if you haven't done anything, or a patient needs their observations done in a particular time frame, we've set those parameters working with the company, that the nurse will be alerted to that. So it kind of removes that issue around not doing obs on time, because the alerts will be there to remind people to go forward and do that. Next slide, please. So we wanted to try and push it a wee bit further. So I had a look around about what else could we do to make this kind of process more efficient. So measuring the kind of test wards and looking at reliability and the improvement in reliability. I'll come to that data later. We started to think about releasing time